It's a very simple structure. So we have the detrusor muscle, that is the bladder wall, and then the same detrusor muscle causes a smooth muscle or internal sphincter, and then this is the voluntary striated muscle sphincter, what is called as the external sphincter, which is under our control for some time. So this constitutes the structure. This is the involuntary or a smooth muscle, and this is the voluntary or the striated muscle. That's all the structure of the bladder. Now, if you see the function is also very simple. The kidneys secrete the urine which comes down into the bladder, and storage is the main function. It can store up to 500 ml, but around 250 ml there is a desire to pass urine. But if the situation is not conducive, we can voluntarily stop bladder contraction so that we can wait for the maximum of about 500 ml where the bladder keeps distending, and after that it is not under our control, there will be evacuation. So the main function is storage and evacuation. So the bladder is normally internal sphincter, external sphincter is closed. When the voiding starts, there will be opening, and then the detrusor contracts, evacuating the urine. That is the function. Now a little bit of your attention for the neural innervation of the bladder. So bladder is basically autonomic nervous system, which means sympathetic and parasympathetic nerve, and there is a voluntary, that is external sphincter, by the somatic nervous system, that is the pudendal nerve. Now the sympathetic system arises from the lateral gray columns from the spinal cord, what is called as a thoracolumbar outflow, that is T1112 and L12 from the intermediate lateral column of the spinal cord. And the parasympathetic nerves arise from the same intermediate lateral gray column, S234. The somatic or the pudendal nerve also arises from S234, but from anterior horn cells, because that is under our control, the upper motor neuron, lower motor neuron. So the sympathetic and parasympathetic nerve, they innervate the bladder. The main work is by the parasympathetic. Sympathetic is more often it is a little bit sympathy in controlling the bladder. Otherwise, the main innervation is by the parasympathetic. And the parasympathetic has got cholinergic receptors, and sympathetic has got beta adrenergic at the detrusor level and alpha adrenergic at the smooth muscle sphincter level. So to repeat again, the autonomic nervous system consists of sympathetic arising from thoracolumbar outflow, parasympathetic from sacral outflow, somatic also from sacral outflow but from anterior horn cell. And it is the cholinergic receptors which are responsible for contraction of the bladder. And finally, please remember, this is the pelvic floor musculature which comes into the discussion when we are talking about the stress incontinence. So whenever the pelvic floor musculature is weak, whenever there is a straining like coughing or sneezing, the increased abdominal pressure compresses the bladder, and then there is a leakage of urine. Now, to put it in a diagrammatic representation, the sympathetic nervous system is from thoracolumbar outflow D11 to L2 from the intermediate gray, goes to the hypogastric plexus, then hypogastric nerve, and then the pelvic plexus. The parasympathetic is a sacral outflow, again intermediate gray S234. Same S234, but from anterior horn cell is the pudendal nerve, which supplies the pelvic floor muscles and most important, the external sphincter. Now let us see how the innervation goes up to the brain. In the spinal cord, we have afferents through the posterior column, which is a proprioceptive. That means the fullness of the bladder is conveyed by the posterior column. The exteroceptive or spinothalamic is for the pain and temperature. So when there is a cystitis or a stone in the bladder, the pain is conveyed by spinothalamic tract, the fullness is conveyed by the posterior column. And from the spinal cord, the efferents are basically the reticulospinal tract from the pons, which comes down to the detrusor, that is for the involuntary control of the bladder. For voluntary control, the corticospinal tract will come and merge at the S234 anterior horn cell, that is the pudendal nerve. So these are the afferents and these are the efferents. The main center for the bladder is called as the pontine micturition center, which is, as the name goes, it is in the pons. The lateral part of pontine micturition center is for storage. The medial part is for evacuation. So this is the most important center for the bladder. However, the voluntary control comes from the frontal lobe. So as you all know, the medial surface of the frontal lobe, it is a bladder area here. Now this is for the voluntary control. So from here it comes down to the, I think somebody is putting these lines. Kindly refrain from doing this, please. So the frontal lobe, please don't put these lines. So from the frontal lobe, the track goes down to the pontine micturition center. This is the voluntary part of it. So this being the main center for the bladder, mainly controlled by the frontal lobe for voluntary micturition, but almost every other structure on the way to the pontine micturition center has something or other to say about it. Predominantly, as I said, it is a cholinergic one. The detrusor contraction. I don't know, once again somebody has put the line here. Can you please stop doing this on the slides? The sympathetic, the detrusor, there is a beta adrenergic. It is meant for relaxation. So sympathetic is for detrusor, beta adrenergic. So sympathetic is for relaxation. Cholinergic is for contraction. The sympathetic of internal sphincter is alpha adrenergic, which is for the contraction. So this is how the innervation takes place. Now let us see how the bladder evacuation starts. There are three loops: step 1, step 2, and step 3. The first loop is from the frontal lobe to the pontine micturition center. This, as I already told you, is a voluntary control. From the frontal lobe through thalamus, basal ganglia, it comes to this. Now this voluntary control, as I said, by 250 ml of filling, there is a urge to pass urine. But you are in a situation where you are not able to evacuate the bladder. So you can tell from your frontal lobe that please wait for some more time. Now this voluntary control we have to develop in the child. As you know, in the children and patients in dementia, this voluntary control is lost. So whenever the bladder is full, the pontine bladder center immediately gets into the action. So this is loop 1 is for volitional control. Loop 2 is the most important one. This is a coordinated reflex which causes total evacuation. So from the pons, it goes down to the spinal cord. So there is a detrusor motor nucleus, reticulospinal tract, as I told you, the descending tracts, and then goes to the lumbosacral gray, that is the parasympathetic S234. The final one is S234, it makes the detrusor to contract, but if the person is not ready for evacuation, the pudendal nerve, that is the on-off nucleus of S234, gets into the action and prevents the opening of the external sphincter so that you can hold the urine for some time. So there are three loops. One is the voluntary control from frontal lobe to pons. Second is the reflex control from pons to the sacral S234. And if voluntarily you are able to stop, it is because of the loop 3, that is from the pudendal motor nucleus, also called as on-off nucleus. So that is about the anatomy and physiology. Now let us go to the clinical part of it. So the clinical part of it is frequency and urgency is one of the symptoms. Normally, we pass urine about 4 to 5 times in a day. It may be more frequent because of several physiological conditions like anxiety. Just before a YOC examination, you may like to go to the bathroom and come, or before you give a performance on the stage, you may like to go to the bathroom, or excessive water intake. There are some youngsters who keep drinking 3 to 4 liters of water because they have read somewhere in the internet, you must keep yourself healthy by drinking more water. All other causes of polyuria like diabetes, CRF, endocrine dysfunction, etc. Pathologically also there can be frequency and urgency, either a stone in the bladder or cystitis or even a carcinoma in the bladder can cause irritation of the bladder, which causes frequent contractions. So there is a frequency and urgency. Then we come to the neurological causes of frequency urgency. The neurological cause is a upper motor neuron lesion. Like in upper motor neuron lesion of the skeletal system, where the if you just touch the quadriceps tendon, there is an immediate jerk because it is hyperreflexive. So similarly, in UMN lesion of the bladder, it is hyperreflexive. So even with 200 ml, where one should not get an urgency to pass urine, the bladder contracts. So when the bladder contracts, there is a message that the bladder is going to contract. So the patient may be able to control for some time, but he has to rush to the washroom. So he keeps on, instead of 4 times, he may go 10 times. So that is the frequency. Then after some time, the bladder contracts so forcibly that there is an urgent need to rush. If there is no washroom nearby, there may be incontinence also. So this incontinence is called as urge incontinence. So frequency, more lesion, frequency, urgency, and more lesion, urgency and precipitancy, or urgency and urge incontinence. If you look at the lower motor neuron lesion, like lower motor neuron in the skeletal system, where it is hypotonic and hyporeflexic. Similarly, the bladder also is hypotonic and hyporeflexic. With the result, the bladder contraction is very weak. So when there is a bladder contraction is weak, the person who goes to the washroom, the urine hesitates to come because the contraction is not powerful enough. He has to wait for some time for bladder to contract. And even if it contracts, there may be incomplete evacuation. So it is just, think about the skeletal system, hypertonic and hypotonic, UMN and LMN. So you can derive the symptoms of UMN and LMN bladder. Incomplete evacuation and hesitancy can also occur physiologically when anxiety or prostatic hypertrophy. Now, how do we differentiate a bladder of UMN type and a bladder of the LMN type? In UMN, as I already told you, urgency, frequency, and urge incontinence. And the symptoms here are hesitancy, difficulty to pass urine, retention, and there may be overflow incontinence. Signs, other signs of UMN. In UMN, the bladder may not be palpable, but here, because of the retention, the bladder can be distended. All other signs of UMN like spasticity, exaggerated reflex, extensor, a lesion in the spinal cord can be seen basically in the thoracic cord. And here the LMN signs, hypotonic, absent reflexes, plantar flexor. Usually the lesion is in the cardi equina. Now, how do we classify the bladder? There are varieties of classification of neurogenic bladder, and I usually teach my students the very clinical type of classification. One is the UMN lesion, which is hypertonic, hyperreflexic bladder. So when the bladder contracts, normally physiologically the sphincter has to open so that there is a total evacuation. So that is called as a hyperreflexic bladder with coordinated sphincter. So even though the person is going for washroom frequently, there is a total evacuation of the bladder because the sphincters open whenever there is a contraction of the bladder. But there is other type of UMN bladder where there is hyperreflexic without coordination of sphincter. So the bladder contracts, the sphincter also contracts. So now what happens? There is a frequency, urgency, but very little urine comes out, and there is a residual urine, even in UMN lesion. Hypotonic hyporeflexic is understandable. With coordinated sphincters, we can treat the patient with what is called as a Credes method. That is, you give pressure to the suprapubic region, the bladder contracts forcibly, and the bladder can evacuate the urine if the sphincters are coordinated and opening up. But if it is not coordinating, even if you use the Credes method by pressure of suprapubic region, it will not open up, and so there is a retention of urine. So please remember, UMN lesion also there is a retention of urine when there is no coordination. LMN lesion also there is a retention of urine when there is no coordination. Now, where do you get the hyperreflexic with coordinated sphincter? Typically, nowadays what we see is in the multiple sclerosis. And as I said, in dementia and all cerebral pathologies. So here the patient passes urine without his knowledge, he cannot control, but there is no residual urine. That's very important when come to management. There is no residual urine. There will be urgency, urge incontinence in multiple sclerosis. There is no residual urine. So how do we treat this? We treat it by pharmacological treatment. That is because the patient has an overactive bladder. We reduce the overactivity by using anticholinergic, because the cholinergic system is the one which contracts the bladder. So use anticholinergics. A list of them are there: oxybutynin, probantin, dialophyrin, all this. Now recently, the beta-adrenergic agonist, as I told you, the beta-adrenergic fiber supplies the detrusor for relaxation. So the beta-adrenergic agonist causes relaxation. That is the one which we use. Mirabegron is a recent addition to the armamentarium of hyperreflexic bladder with no residual urine. Please remember, no residual urine, you can use this. If there is a residual urine, you cannot use this. Now, where do you get without coordination of sphincters? Advanced spinal cord, either spinal cord injury is much more severe, or there is a myelitis is more severe, or there is a advanced multiple sclerosis. How do you differentiate the with and without coordination? There will be high residual urine. In spite of patient having frequency, urgency, you can palpate the bladder. So that is the high residual urine. Is very, very dangerous because it will have back pressure effects, it will have infection, and the patient may have overflow incontinence because of too much of fullness. Now, back pressure effects will cause hydronephrosis and renal failure. So here what is happening is the sphincter is not opening up. Now, because the sphincter is not opening up, there is a possibility of making the sphincter less active by doing a transurethral resection, anticholinergic plus transurethral resection, or the clean intermittent self-catheterization. Now, hyporeflexic bladder with coordinated sphincter, as I said, partial cord lesion or diabetic autonomic neuropathy, there is a hesitancy, overflow incontinence. We can try mechanically press the bladder by Credes method, that is suprapubic pressure, or use cholinergic drugs like bethacoline. If both of them fail, go for CISC. Now, hyporeflexic without coordinated sphincter, there is no other choice except for clean intermittent self-catheterization because there is a high residual urine. Now, oftentimes there are references of patients who have urinary symptoms. The urologist will check everything and say that nothing I could find, so go to the neurologist. And the question is whether the bladder symptoms, whatever it is, frequency, urgency, or hesitancy and retention, is it neurological or is it urological? The golden rule is isolated urological symptoms are not due to neurological cause, which means if you examine, if you take history properly, there are no friends of symptoms. tingling, numbness, paresthesia, difficulty to walk, imbalance. No such history is there. And examination shows normal motor system examination and normal sensory system examination done carefully in the lower limbs. Then you can almost always say that the problem is not neurological. So please remember this golden rule. But don't forget, don't forget to check the perianal sensation. There was one boy who had a fall and a fracture of L1 vertebra, and after 2 months he started having difficulty to pass urine, no difficulty in walking, no sensory symptoms, examination, motor system, sensory system, everything normal. So it was referred to rule out a neurological problem. Now all you have to do is turn the patient and check for perianal sensation. Most important clinical rule to rule out a LMN type of bladder where the patient may have no symptoms and signs in the lower limbs is to look for perianal anesthesia. It is the same segment as S234. So if S234 parasympathetic is involved, you can see a corresponding sensory loss in the S234. There are other treatment options apart from pharmacological, advanced treatment options like sacral neuromodulation, intravesicular Botox to reduce the frequent contraction of the bladder. Then patients who have small bladder, they can have augmentation of the bladder with intestinal anastomosis and all that, but that is advanced treatment. Let us not go into that. What about the investigations? Of course, the basic investigation will be about the urinalysis, and very, very important. Many times I find in multiple sclerosis, people do only MR scan, CSF, MR scan, CSF. But please remember, even though the patient does not complain of any sensory problem, any bladder problem, why they don't complain? Because their main emphasis is on difficulty to walk or imbalance. So they don't bother much about the bladder problem. It is mandatory to do an abdominal ultrasound to look for any back pressure, pre-void, full bladder capacity, and post-void. More than 100 ml post-void is a significant, which requires a intermittent self-catheterization. Now, there's one catch here. When you do an ultrasound in the clinic and ask them to go and pass the urine and come back, it may be 150 ml. You tell them to go back immediately and what we call as a second void. So second time they go, but within 10 minutes, not after half an hour, 1 hour. Within 10 minutes, they should go back and come again and do that. You may find that it's only 50 ml. So please remember that there should be a second void within 5 minutes. And if that comes less than 100 ml, you can still go for pharmacological therapy. There are other advanced investigations like uroflow rate, cystometrogram, EMG, video aerodynamics and all. But a large number of bladder symptoms due to neurological causes can be managed only with this and the associated neurological problems of paraparesis. Now, whether it is a UMN bladder or LMN bladder, whenever there is more than 100 ml residual urine, pharmacological treatment is not going to be sufficient. The patient may be very happy with pharmacological treatment, is able to pass urine, but look for residual urine. If the post-void residual urine is more than 100 ml, irrespective of UMN and LMN, clean intermittent self-catheterization is the important management. Of course, the patients will definitely say that they don't want because it is a cumbersome procedure and all that. It takes some time for patients to be well educated. It is very safe and effective, and the person himself can do it, and there will be retention will not be there. There's no risk of damage to urethra. They are not dependent on anybody else. It reduces the symptoms of frequency. Infection will not be there. Back pressure effects will not be there. And it is not necessary that you have to use catheter every time, sterilized one. The normal catheter can be washed with soap and water under the tap water and hang it. Once it dries, put it in a plastic cover put it in the pocket and go for a party, and then in the party in between, after a couple of beers, you can go back to the washroom and have a self-catheterization and come back and enjoy the party. So that is a very important, but it requires a lot of motivation and training. That is the most important CISC whenever there is more than 100 ml residual urine after second void. When do we use indwelling catheter? Whenever the intermittent catheter is not possible. Either it is not possible because the patient is having a upper limb paralysis, or it is not possible because he is not able to understand, or he simply does not want to do it himself. So in that situation, indwelling catheter has to be done. Now, indwelling catheter can be urethral or suprapubic. If the indwelling catheter is going to last longer, if it is something which is a reversible like a MS with a indwelling catheter, you expect that the patient's spinal cord improves, then urethral catheter is okay. But once you decide that this is a permanent spinal cord injury, then you will have to go for a suprapubic indwelling catheter. Very, very important. Many doctors, many physicians, they get the urine culture done, urine examination done, because there is an indwelling catheter every 10 days, 15 days, and it shows plenty of pus cells and bacteria. Don't treat bacteriuria and pus cells on urine examination. Patient should be symptomatic. If he has fever, rigor, then it is a urinary tract infection and you will have to do culture sensitivity and give appropriate antibiotics. Otherwise, there is no need to treat asymptomatic bacteriuria. Another important point, no prophylactic antibiotics. No prophylactic antibiotics. Wait, if and when there is a urinary infection, you can do it. Now, we come to the, suppose a patient comes to us for urinary incontinence. What is urinary incontinence? It is involuntary loss of urine, objectively demonstrable, and is a social or hygienic problem. Now here, the patients may come to us and saying, doctor, I am wetting my underpants frequently. I am not able to control it. Now, is it a UMN bladder, or is it a LMN bladder with overflow, or is it what is called as a urge incontinence? It's very important to differentiate. Urge incontinence is not a neurological problem. Urge incontinence is not a neurological problem. Overflow incontinence, where the bladder is full and then it opens up, or urge incontinence, where the bladder is highly irritable, is different from what is called as a stress incontinence, which is not a neurological problem. So what are the types of incontinence? Urge incontinence, which you have already talked about. Overflow incontinence we have talked. Now let me just tell you a couple of sites. What is called as genuine stress incontinence. The stress is an increased intra-abdominal pressure. Detrusor is unaffected. The nervous system is perfect. When the bladder is full, whenever there is an increased intra-abdominal pressure, normally the pelvic floor prevents the opening up of the smooth muscle sphincter. But if the pelvic floor is damaged and pelvic floor is lax, then because the pelvic floor is lax, when the bladder is pressed because of increased abdominal pressure, the urine leaks away. They don't have a incontinence of 100 ml, 50 ml. They just leak about 5 ml or 10 ml due to increased abdominal pressure. So how do you make a clinical diagnosis? Very simple. The involuntary loss of urine occurs only when there is a raised intra-abdominal pressure, not when a person is quietly sitting or lying down. So almost exclusively it is seen in women because the pelvic floor is damaged due to repeated deliveries, fortunately which is not occurring nowadays. In the olden days, where they had 6 children, 8 children, forceps delivery and all that, so perineal tear. So those are the people who are likely to develop this stress incontinence. But nowadays, hardly people opt for children even if they are married, or they don't want normal delivery, they want cesarean. So this GSI has come down considerably. Otherwise, it is very common in women above the age of 40 years. because of pelvic floor weakness, or botched up prostatic surgery in male, where they damage the pelvic floor also can be responsible. So as I mentioned, the genuine stress incontinence is due to raised intra-abdominal pressure. When does the raised intra-abdominal pressure occurs? Whenever you are straining, you are lifting a bucket of water or a weight, or you are increased the abdominal pressure by holding your breath while playing, or even simple sneezing or coughing, or even a hearty laugh. We all welcome a very hearty laugh because that also spreads happiness to the people around. But the woman who has a hearty laugh will immediately feel a few drops of urine getting into the underpants. Most of them won't even come to the consultation because they are they have a inhibition to come and tell about this, but only when it becomes very frequent they come and tell us. So please remember, in a 40 plus woman complaining of incontinence, the quantity of incontinence is very small and is related to the stress. Now how do you differentiate a neurogenic urge incontinence from stress incontinence? The symptoms are urgency, frequency, and urge incontinence. And here it is urge incontinence with previous history. There are other signs of UMN like hypertonia, hyperreflexia. The neurological exam is normal, and when you do the abdominal ultrasound, pre-void and post-void may be abnormal, whereas here it is normal. Management here is anticholinergics. Here it is to strengthen the pelvic floor exercise, what is called as a Kegel's exercise, vaginal cones. One may use alpha-adrenergic agonists like pseudoephedrine and other pharmacological treatment like imipramine and ephedrine and hormone replacement therapy. I still have another 10 minutes for you people to ask me questions. Remember, neurogenic bladder most often is diagnosed with what I call as a tell me who your friend is, the associated neurological symptoms or signs. And one of the important signs is to look for perianal anesthesia, and clean intermittent self catheterization is the mainstay when pharmacological treatment fails and residual urine is more than 100 ml, irrespective of whether it is a UMN or a LMN lesion.